Madam Chair, we're now live on YouTube.
Good morning, everyone. This is the Public Employee Benefit Program meeting on September 26th, 2024, and it is 9 a.m. We're conducting this meeting from Carson City. I'd like to call the meeting to order. Would staff please call the roll?
Good morning, everyone. Starting roll. Chair Grimmer,
Present.
Michelle Kelly,
Present.
Jim Barnes,
Here.
Jennifer McClendon,
Here.
Betsy Strasburg,
Present.
Janelle Woodward will be late this morning, but she will be attending, and Stacy Weeks is absent. Please remember to state and spell your name for our transcriber. Thank you.
Okay, we will move on to item number 2, public comment. Public comment will be taken during this agenda item. No action may be taken on any matter raised under this item unless the matter is included on a future agenda as an item on which action may be taken. Public comments to the board will be taken under advisement, but will not be answered during the meeting. Comments may be limited to 3 minutes per person at the discretion of the chairperson. Please state and spell your name when you make public comment. And we'll start in Carson City. Do we have any public comment?
Good morning, Kent Irvin, ERVIN, representing the Nevada Faculty Alliance, the statewide association of professional employees at our public colleges and universities. Regarding the plan design discussion, many of our constituents rely on the health maintenance organization or exclusive provider organization plans. They willingly pay more per month in exchange for certainty over future costs. In the South, many rely on the HMO from Health Plan of Nevada for access to providers that are not available in the self-funded plans, including essential mental and behavioral health providers. The outpouring of public comment against the elimination of the HMO EPO plans tells you what you need to do. There has been migration to the low deductible plans, which means it's been a success. But there's much more migration from the high deductible plan than from the HMO EPO. With the current employer contribution structure with the same subsidy for all 3 plans, the cost to PEB is the same regardless of the member's choice of the plan. If members in the HMO EPO do not understand that it does not have an out-of-state provider network, then that means PEB needs to do better communications at open enrollment time. So none of these factors are a good reason to eliminate the HMO EPO. Also, the HMO EPO premiums for a family are actually lower in FY 2025 now than they were in FY 2021, $652 to $690 per month. While the employee premiums for the high deductible fund or for the self-funded plans, the high deductible plan for a family increased during that time from $301 to $352. More broadly, the 3 plans are not well differentiated, and that should be fixed. The HMO EPO should have a 0 deductible and no coinsurance. That's what people expect from an HMO. We never understood the reasoning for switching the low deductible plan to a 0 deductible plan, which makes the immediate coinsurance problematic. Restoring a modest deductible to the low deductible plan would better place it in the middle of the 3 plans and could reduce monthly premiums. Finally, since the deductible on the high deductible plan is now indexed to inflation per the IRS minimums, the health saving accounts contribution should also be indexed to inflation, say at 50% of the deductible amount. That would restore the pre-pandemic percentages. Board members, please reject the elimination of the HMO EPO plan. At a minimum, any decision should be deferred until the request for proposals and when you know the cost and whether a statewide HMO is available. A statewide HMO would be ideal. An out-of-state provider option for the HMO would also be ideal. In particular, our ELCO participants need to be able to use specialists in hospitals in Salt Lake City. Finally, the solution to higher cost is a higher employer contribution from the state, not a reduction in benefits. Reducing benefits every time costs go up is a death spiral. Thank you.
Thank you.
Good morning, Chair and members of the board. My name is Tess Opferman, and I am here on behalf of the AFSCME retirees. Though most of our members are retirees and are on Medicare, we do have some retirees who are pre-Medicare or are still on the healthcare plan, the PEB plan. And so we echo everything Kent just said. I think he said it very eloquently, but we feel strongly that the HMO EPO option should still exist, and we ask you to continue to support that. Additionally, as you consider plan design, the retirees continue to talk about our HRA supplemental payment. They have received, the calculation is $13 per month per year worked that the retirees receive, and that number has not changed since 2015. We have asked the legislature to increase that amount, but we also want you to continue to consider that it really needs to go up. As healthcare costs go up, our retirees are paying for those increases out of pocket. Some of our retirees are paying $600 out of pocket to cover their healthcare costs that when they worked for the state for 30 years, they were promised that those healthcare costs would be covered throughout their retirement. The state is not upholding that promise, and through this switch and the supplemental payment, that is how they were supposed to have those things covered. And that amount has not increased at all in nearly 10 years. So that will certainly be our ask of the legislature this upcoming session, but we also ask you to consider that amount through these plan designs. And then lastly, we've gotten summary reports from a few of our retirees who are frustrated about the transition time when they retire, the amount of time it takes them to start receiving the HRA supplemental payment, 12 weeks or 3 months. That's a really long time to be waiting on a check and waiting for a little bit of coverage to help through that transition. So we just want you to be aware of that. Like I said, we've received some complaints through AFSCME, and we want to make sure that that's considered, and as much as possible, we can speed up that timeline. So thank you, and we'll listen to the meeting today.
Good morning. My name is Lisa Partee. I've never been to one of these meetings, and I had no idea this was an issue until yesterday. I've been on the HMO since the inception of my state time. I do it to avoid medical bankruptcy. I know what I'm getting. I know what I pay. I know I'm capped at certain things. Please do not take away the HMO. I rely on it. Thank you.
Good morning. I also didn't know about this meeting until yesterday. My name is Shelley Shannon, Shannon, and I'm a Carson City resident and a 2-year retiree. I also am on the HMO. I had no idea that you were even thinking of getting rid of it, and I'm begging you to not. I've looked at through my years at the state, I looked at all the options. And the HMO, I don't have kids, and I'm gladly paying more for accident coverage, basically. Again, like Lisa said, to avoid medical bankruptcy. I'm willing to pay the higher premium. I've done the high deductible. I was inadvertently thrown into it 1 year, and I'll never want to do that again. I want my HMO. Please don't take away the HMO. Thank you. And I echo what both said. Amen.
Is there any further public comment in Carson City?
Sure. Can I just, for the record, show that I came into the meeting just a little bit late?
Yes.
Janelle Woodward, for the record, I entered just at the start of the public comment. Thank you.
Thank you. Okay, seeing none, we will move to public comment online.
One moment, Madam Chair, I'll get the slide up.
Thank you.
For those who have joined for public comment, your name or last 4 digits of your phone number will be announced. You will be advised you have been unmuted. Please slowly state and spell your name for the record and then proceed with your comments. As a reminder for those on the phone, please press *6 to unmute. Due to time consideration, each call will be limited to 3 minutes. We have a lot of people in the lobby today, so please, if you do not want to make public comments, please watch the YouTube live stream instead. We have about 20 attendees in the lobby right now, so I'll get to you when I can. Thank you. Debbie Ortega, please slowly state and spell your name for the record if you wish to make a public comment.
Yes, good morning. My name is Deborah Arteaga. That's DEBORAHARTEAGA. and I have the privilege of serving as chair of the Faculty Senate of UNLV at this year and representing almost 700 academic and administrative faculty members. I am also speaking on behalf of Dr. Ginger Doe, Faculty Senate Chair of Truckee Meadows Community College, who could not attend this meeting. Simply put, the changes that are proposed constitute a pay cut for our faculty members. It does no good to finally receive COLA if we pay more out of pocket for healthcare. Eliminating the HMO option would be devastating to our faculty members. I understand that statewide, 20% of employees are on this plan. I understand that it is expensive, but I would submit to you that it is a benefit, and good benefits help us hire and retain faculty and improve faculty morale. Transitioning the low deductible PPO to a standard PPO is also concerning. Although the board has proposed that the standard PPO have no deductible, we have no information about what the payment structure will be. The monthly cost to the employee, co-pays, and co-insurance. For example, statewide, 30% of employees are on this plan. Finally, we received the email from PEBP regarding this meeting at 10:01 a.m. on September 24th, 2024. That means we had no time to submit written questions or comments because they must be received 2 business days before the meeting. I respectfully request that you not do this in the future. Thank you.
Thank you. David Kelsey, please slowly state and spell your name for the record if you wish to make public comment. Harisa, you have permission to speak. Please slowly state and spell your name for the record if you wish to make public comment. Caller with the last 4 digits, 7832. Please press *6 to unmute and please slowly state and spell your name for the record. Caller with the last 4, 8877. Please slowly state and spell your name for the record if you wish to make public comment. Caller with the last 4, 9269. Please slowly state and spell your name for the record if you wish to make public comment. Doug Unger, you have permission to speak. Please slowly spell and state your name for the record.
Doug Unger, DOUG, UNGER, President, UNLV Chapter, Nevada Faculty Alliance, and Chair Government Affairs Committee. First, a warm welcome to Director Joy Grimmer, and thank you to you and the PEB Board for your service and consideration. Regarding agenda item number 6, the proposed plan design for next fiscal year, our faculty and staff, as you're seeing, are only just now getting the news that the HMO plan in the South may be eliminated, and so full feedback is not yet available. Though only approximately 18% of our faculty and staff are enrolled in the HMO, this plan has been a welcome option for employees whose income security depends on predictable healthcare costs that the HMO plan satisfies. Not everyone is able to pay high deductibles or copays in case of emergencies. The HMO balances out costs over the plan year. As well, the greater Las Vegas area suffers from a severe shortage of certain healthcare provider specialties that are more available through the HMO than the PPO or CDHP plans. Most urgently needed among them, behavioral healthcare specialists. I am hearing from faculty who are most concerned about losing trusted therapists for themselves and their families should the HMO be eliminated. Speaking now only from the point of view of employees of the Nevada system of higher education, the board should understand that universities and/or university systems in all the surrounding states in the region offer at least 3 or more plan options, including an HMO or an EPO. Some of these are admittedly HMO or EPO plans organized and offered through university medical schools, so they function as nonprofits instead of for-profit plans offered by large insurance corporations. Nevertheless, the choice is there. Faculty research health coverage options when deciding to stay in or to accept a position at a university or college. So cutting the HMO plan in the South could at least somewhat affect retention as well as future hiring. We deserve a third choice. We ask the board at least to postpone the elimination of the HMO and EPO until the results of the RFP for either or both is known in the coming months. Please consider this potentially very disruptive decision most cautiously. Thank you.
Thank you. David Cooper, please slowly spell and state your name for the record if you wish to make public comment.
Hello, my name is David Cooper, DAVID COOPER, and I am Assistant Professor of Chemistry at Nevada State University, and I'm also currently serving as the Chair of the Faculty Senate at NSU. I'm here today to speak in favor of retaining the HMO option for our employees. Around 1/5 of the faculty are currently on the HMO plan and prefer the certainty of payments that the HMO plan offers over the other options, even if it does include an initial increase in cost. The HMO plan includes some providers who are not covered under the low deductible or high deductible option, requiring our faculty to need to switch should the HMO plan be discontinued. With this in mind, and in support of some of the other speakers that have been here, please consider not canceling the HMO plan. Thank you.
Thank you. Will the ASL/English interpreter 15309 please slowly state and spell your name for the record if we wish to make public comment? GC or Golf Charlie, you have permission to speak. Please slowly spell and state your name for the record if you wish to make public comment. Gina Gamble, you have permission to speak. Please slowly state and spell your name for the record if you wish to make public comment. One is just called iPhone. You have permission to speak. Please slowly state and spell your name for the record if you wish to make public comment. Okay, as a reminder, if you do not wish to make public comment, please leave the attendee lobby of the Zoom webinar. You can watch the meeting or listen to it live on YouTube, which is located on the agenda, which you can find on the PEB website. Jackie P, you have permission to speak. Please slowly state and spell your name for the record if you wish to make public comment. Monica Rosales, you have permission to speak. Please slowly state and spell your name if you wish to make public comment.
Hello, my name is Monica Rosales. My first name is spelled Monica, last name Rosales. And yes, I wanted to comment saying that the short notice was not cared for particularly, especially since we were only given notification on Tuesday. And I am in great support of retaining the HMO. I'm happy with that plan. I can only speak on my own experience, of course, but I purposely chose this plan. I know it's not the most popular plan in comparison to the others, but it's the one I'm most happy with, and I'm happy to spend a little bit more for the premiums because I feel like I get more out of it than I would with any other plan. And that's really what I wanted to say, and I hope the board will consider it.
Thank you. Stacy Fernandez, please slowly state and spell your name for the record if you wish to make public comment.
Hi, good morning. My name is Stacy Fernandez, STACYFERNANDES, and I am currently logging in from UNLV. I've been with UNLV for close to 9 years, and I have been with the HMO plan ever since I started working here at UNLV. I specifically chose this plan because it was the best fit for my needs, and I am currently pleased to say that I am pregnant, and without this plan, my baby would not be able to have any good health coverage. Please reconsider not getting rid of the HMO plan, and again, as many others have said, it was not a welcome late notice to have been told that this plan was going to be removed. Please reconsider, do not get rid of this plan. Thank you.
Thank you. Apologies, I don't want to butcher your name. Oziema, please slowly state and spell your name for the record if you wish to make public comment. Timothy Holt, please slowly state and spell your name for the record if you wish to make public comment. David Kelso, let's try you again. Please slowly state and spell your name if you wish to make public comment. Caller with the last 4 digits 3631. Please press *6 to unmute, and please slowly state and spell your name for the record if you wish to make public comment. *3631. I see that you're unmuted. Doesn't look like you're speaking though.
Yes, can you hear me?
Yes, we can.
Okay, my name is Timothy Hoft. My name is spelled TIMOTHYHOFT. I am a professor at UNLV. I have been here for over 12 years now and have always been on the HMO plan. I have a very serious chronic illness, which the HMO plan is the best option for me. If I were to be thrown off the HMO plan, it could have catastrophic consequences for my health and for my finances. And so I'm begging you, please do not eliminate the HMO plan. Thank you.
Thank you. Caller with the last four digits 0522. Please slowly state and spell your name for the record if you wish to make public comment.
Hello, this is Laura Naumann for the record, LauraNaumann. I'm faculty at Nevada State University and have been there for 12 years. I have also been on the HMO for the duration of my time here. I grew up poor without any access to healthcare, and I've lived having to decide whether or not I should go to the doctor because of if I could afford the hospital bill. The HMO provides really needed, I pay more for the premiums every month, but I know what I'm going to pay when I walk into the office. I know my copay. My preventative care is free. My whole pregnancy, I went in without ever having to pay anything because it was all covered as well care. I'm very worried that because of cost-saving measures, you'll cancel the HMO. If we do go that route, I think the board really needs to consider the types of messaging that it gives to the long-term HMO participants in terms of how it will impact what it looks like when they go to the doctor and what they will be expected to pay beyond the copays. What is 80% of a colonoscopy? What is 80% of giving birth? Those are costs that I have not ever had to think about, that it will require allocating and thinking differently about monthly savings because many of us cannot afford a very large bill all at once. So I ask you to please consider those impacts that if we are moving to only PPO, also all of us are going to have to find new healthcare providers. Healthcare in the South is very hard to find providers that are accepting new patients. So it's going to be a major impact. I'm done with my comment, but I want to make sure that you are able to get David Kelsey. He's deaf and he needs the ASL interpreter to share his comment. Thank you.
I don't want to butcher this one. I think it's Carice. You have permission to speak. Please spell and state your name for the record if we should make public comment. Looks like they left. Madam Chair, that's all we have in the Zoom lobby. There is a lot in here, so please, everyone, if you do not wish to make public comment later in the meeting, please leave before that public comment section, or otherwise I'm going to have to go through the list again. Thank you.
Okay. Do we have any further public comment?
Hello.
One moment.
Morning.
I gotta switch the camera.
Thank you. Good morning. My name is Kelly Osborne, KELLY OSBORNE. And I'm here to address the board. Thank you for first and foremost for being here, for serving the state of Nevada, for serving all of us employees. I'm here to ask you to please be cognizant of what is happening with the contract with Carson Tahoe Hospital and UMR. Like many other state employees and retirees, we received a memo from Carson Tahoe saying that they were canceling the contract with United Healthcare, which is a subcontractor under UMR, which you guys all contract with, stating that they're canceling the contract based on bad payment, performances, and all of that. I understand that it's a non-issue now, and it may be Carson Tahoe strong-arming you guys, but there's a lot of us affected by this. And when I called the board, when I first got this memo, I was told that it's not your guys' problem, that it's my problem, and that I needed to contact UMR myself. Somebody who has chronic health conditions is affected. Every one of my doctors, besides my transplant doctors, are in Carson Tahoe or in Carson City under Carson Tahoe Hospital. So it's an issue. It's a big issue. And it's not just for me, it's for everybody else. So I did contact UMR at your receptionist direction, and UMR said it's not a problem. But it's never a problem until it becomes a problem. And so I just want you all to be cognizant of this and until it becomes a problem. And it could be Carson Tahoe strong arming you all for more money, UMR for more money, United Healthcare for more money. I don't know. I'm not a contract manager anymore, but it will be an issue when it becomes an issue. So I just wanted to bring that to you guys' attention. Thank you so much.
I'm sure. That one of the last callers referred to that ASL translator, that they want to make a public comment, they're raising their hand. So is it all right if I go back?
Yes.
Okay. One moment, please. Will the ASL English interpreter please slowly state and spell your name for the record? We can't hear you if you're speaking. Your hand is up. Yeah, it looks like your mic is getting muted, unmuted. If you're still having technical issues, we'll just get you at the end of the meeting. It does look like David Kelsey is back, though he raised his hand. David Kelsey, please slowly state and spell your name for the record if you wish to make public comment. Sorry, for those who keep on raising your hand, if you're not speaking, I can't do much else. We'll circle back to them at the end of the board meeting. Madam Chair, apologies.
Okay, thank you. Okay, any further public comment here? Okay. Seeing none, we'll close agenda item number 2 and go to agenda item number 3. PEB board disclosures for applicable board meeting agenda items. Deputy Attorney General Radhika Kanal.
Good morning, Madam Chair and board members. This is Radhika Kanal, Deputy Attorney General for the record. This agenda item is to allow me to make a disclosure regarding conflicts of interest on behalf of the board members who are eligible for PEB benefits. Pursuant to NRS 281A.420, on behalf of the board members who are eligible for PEB benefits or whose families are eligible for PEB benefits, I offer this disclosure that they will be voting on those items that may affect the benefits available to them or their family members. The law does not require abstention from voting merely because the board member or their family member is eligible for PEB benefits. At this time, I invite any member of the board who has any additional disclosure to make it now. Thank you.
Okay, seeing no additional disclosures being brought forward, I will close agenda item number 3 and move on to agenda item number 4. Consent agenda.
If I may make a comment before moving on to the next agenda item, having heard a number of comments on the during the public comment session that they have received some sort of notice and within the last day or two, I would like for somebody from the PEB administration to comment on the notice, just to ensure that the notice requirement meets the Nevada OML law or open meeting law requirements.
This is Celestina Glover for the record, Executive Officer for PEB. The agenda was posted on Friday. Once it's out of our hands and into the system to get publicly posted, we don't have a lot of control over that, but it could get posted as late as 11, 12 o'clock at night. So the agenda did go out. We have routine meetings on the right around the 22nd to the 25th of the month, every other month. So we do have a standing schedule for our board meetings, and the agendas typically are posted a week before that board meeting happens. So if you have a question about whether a meeting is coming up, you can always contact PEB and we will let you know when the next one is scheduled. So if there is something on the agenda that you want to participate in, make a public comment on, or submit written public comment, you can get that in a timely manner.
Okay, thank you.
Thank you, Madam Chair. Thank you, Ms. Tina.
Okay, so we'll now close agenda item number 3 and move on to agenda item number 4, consent agenda. All items for possible action, consent will be considered together and acted on in one motion unless an item is removed to be considered separately by the board. Is there any item the board members wish to have pulled?
Michelle Kelly for the record. Can we pull 4.1? I wasn't present at that meeting, so I can't vote on it.
Okay. Okay, any others?
They're working on this.
Okay. Seeing no other items, do I have a motion to approve all of the items except for 4.1?
So
Second.
All right.
This is the court reporter, and I unfortunately do not know all of you board members. And so if you could state your name before speaking, I don't know who made the motion or who seconded.
Michelle Kelly for the record. I made the motion to accept 4.2 of all items in the consent piece except 4.1.
Betsy Strasburg, second the motion.
Okay. Any further discussion? All those in favor signify by saying aye.
Aye.
Any opposed? Okay, motion passes. And now we vote on this other one separately. Okay, do I have a motion to approve 4.1? Approval of action minutes from the July 25th, 2024 PEB board meeting.
Janelle Woodward, I'll make the motion to accept the minutes as written. Second, Betsy Strasburg.
Okay. Any further discussion? Okay. All those in favor signify by saying aye.
Aye.
Any opposed? Okay, motion passes. We will close agenda item number 4 and move on to agenda item number 5. Executive Officer Report, Celestina Glover for information and discussion.
Good morning again. This is Celestina Glover, Executive Officer for the Public Employees Benefits Program. Before you is the Executive Officer Report. It provides general information to the PEB members, board members, and stakeholders. There's only a few things that I've included this time. The first one being the budget update. For those who may have reviewed the budget report, you see where we ended the year. We have had some significant expenses. We were eating into catastrophic reserves to make sure that we can meet our obligations for the year. That is affecting our availability of beginning cash, because whatever we have left in one year, we balance forward to the next. We saw a $43 million shortfall to balance forward cash from 2024 into 2025. So some of what we're discussing today is predicated on what available funding we have and what we believe we may receive during the upcoming legislative session. So I just wanted to make sure that the board was aware that, you know, we are in some pretty restricted positions with funding at this point in time, and we don't know where we're going to land with 2025. And obviously I can't predict what the legislature will do in the upcoming session. Speaking of which, the upcoming session starts in February. We have submitted our budget report per the governor's finance office direction, which was due on August 30th. We did start tracking some of the BDRs that we're seeing out there. The last time I looked was about a week and a half ago. There was 520 DVRs posted at that time. I know personally I have like 120 on my list because we're tracking anything that says related to healthcare, related to mental health care, related to insurance, because there's no language yet for us to look at. Anything that might affect PEB and the program and its members, we're trying to keep track of. Once we see language, we'll fine tune our list of BDRs that we're tracking. We know some will become bills, some bills will die in committee before they even get heard. So as we get the information, we start identifying bills that will affect us. We will be having meetings, as we have done in the past, to discuss potential bills with the board for direction on what action they would like us to take. We have the strategic planning meeting coming up. That is the 1st and 2nd, which is next week. We have an agenda of items we are going to be speaking about, and essentially what we're looking at is where we are today and where we believe we should be taking the plan. We'll be discussing potential options for benefit offerings in the future, plan design changes that might come out of this board meeting, and a whole host of other ideas that our vendors will participate in helping us kind of flesh out. Any brand new ideas that are not just simply plan design adjustments, but new programs, we are looking at plan year 27 to ensure we have sufficient time to analyze those options, bring them back to the board for discussion, and really look at, is that something that we can support? Can we afford it? Is there an interest in utilizing those benefits? So all of that will come out of the strategic planning meeting, and we will be bringing back information from that meeting at the November board meeting and board meetings thereafter for further discussion. And then finally, we have the Medicare open enrollment. This is just a reminder to our Medicare retirees. Open enrollment starts in October. It begins the 15th through December 7th. Please ensure that if you are on Medicare and you're enrolled through VIA, if you wish to make any plan changes, that you continue to enroll through VIA. If you enroll in a plan outside of VIA, you run the risk of losing your basic life insurance and your HRA funding. So it is critical that if there's a plan option you're looking at, you've seen a commercial, you've read an ad, your next door neighbor told you, whatever it is, make sure you contacted VIA to ensure that one, that option is available on their platform, and two, that if it is, you're enrolling through them. We are going to have some HRA specialists in the office for the Medicare exchange on November 6th and November 7th. They're going to be here to assist members with either transitioning into VIA or assisting them with any current issues they may be having. And there's also a phone number. It's listed in my report. It's also on the website. It's 1-844-266-1395, and you can schedule an appointment with the specialist at that time. For more information, keep track of it on our website, and also you can call VIA directly. You can also call PEB, and we will provide you whatever information is asked for, if it's within our power to do so. And with that, I'll take any questions.
Chair, for the record, Janelle Woodward, for the record, just a question. I've had a number of stakeholders or participants reach out regarding this meeting, and wondering if you can explain the reason for not having that as an open meeting that people can participate in. You know, there's some discussion on what are they trying to hide, you know, the typical type things that come up, but if you could just address that, that would be great.
So this is Celestina Glover for the record. The strategic planning meeting is an internal meeting between staff and vendors to flesh out ideas to bring to the board. It's like any staff meeting I would have with my staff or one meetings I may have with vendors. They're not public meetings. We don't invite members to come and sit in my office at all the meetings I attend. It's just not, it's not always appropriate. And there are times where we need to talk about information that isn't appropriate to say in a public meeting, because if we're talking about any particular situation, if I'm addressing your situation, you don't want the rest of the world to know about it. So it's sometimes it's sensitive information we're talking about. So it's just a way of figuring out where PEB is now, where we think we need to take it, and all that information. Once we decide which things we're going to be looking at, we'll always come back to the board.
Thank you.
Betsy Strasberg, Director. Can you please help me for my clarification? The open enrollment will not have the changes that was the subject of all the public comments earlier, correct?
This is Celestina Glover for the record. So open enrollment, that's a forum for members wishing to change their existing plans. If we make a plan change, all that information will be discussed and voted on by the board, and then documents will be updated and that information will get out on our website. So there will be some things that we'll be looking at. So this meeting and the next meeting, those will be things we'll be looking at for the upcoming open enrollment. If there's any plan changes, things that are coming out of strategic planning will probably be for the following year, depending on what it is.
Okay, Michelle Kelly. I just got a couple of questions. The first one, Executive Officer, I was interested in the budget update. I thought I'd wait for you to talk about it. I guess I'm a little concerned and confused. You know, I understand that anything you submit to the GFO is confidential, but I wonder, honestly, I wonder how the board's meant to do its job. If we're talking about plan design, we're talking, you're telling us we're basically in the red, which I have a question about, but how are we meant to design a plan for our participants when really we don't know the finances? And kind of that leads me to, I've suggested it before to the horror of staff, but, our plan year is not designed for the fiscal year because we don't have any certainty and we're having to finalize plan design. So I'll stop there for now.
So this is Celestina Glover for the record. As far as the budget submittal, when we submit the budget, we use existing plans designed the way they sit. We make no changes unless something has come up, like we know that the deductible is going up to maintain the CDHP. So things like that are considered. But typically what we do is we assume no changes, and then we look at where we are today with the budget. And do we have a shortfall? Do we have an excess? And we adjust our budget request to account for that. We're not in the red. We're just very restricted with the funding that we currently have. A lot of it is because over the last 3 years, I've seen significant increase in claims cost. Even the HMO renewal this last go around was double-digit renewal. So all of that plays a part in our overall financial health. And then anything that we approve that enhances benefits. So a lot of decisions were made in prior years to use excess reserves to either decrease premium, increase HSA or HRA contributions. And those excess reserves weren't there. They weren't available. So that came out of the regular funding, which then tightened us even more as to the cash that we've had on hand to pay bills. So we're not in the red. I'm just very cautious with where we are now because I've seen that shortfall compared to what we were budgeted for.
Okay, thank you for that explanation. That makes sense. So then I just actually, Medicare open enrollment was a really simple question. I just wanted to confirm this information you've provided here is not different from past years. You're just reminding people how it has to work.
This is Celestina Glover for the record, correct?
Thank you. I just wanted to, I was reading it and I'm like, I'm not sure I've ever seen it spelled out in this detail before. So I just want to confirm it's nothing new. Okay.
Celestina Glover for the record. I just want to say on the Medicare, the reason I put the reminder in there, because we do have a number of people every single year that even though they've been in the exchange for a long time, we still get some that somehow get mixed up and end up enrolling in XYZ plan over here with a broker, not realizing or not thinking about the fact that they needed to go through via. It happens. We don't know why it happens. You know, it sounds like a good deal. And so they go down the good deal path and then they get sideways. So we always try to help them. But sometimes we're not even made aware of it until a couple of months after the start of their plan year, which is January 1st. So.
Great. I really actually appreciate the reminder for everybody. And I think it's good for us to know as well, because we do, I know in the South, I think people fall into that trap because so many people are selling like, I guess it's quite lucrative, right, to sell these Medicare exchange programs. And so if your neighbors, you know, that you know really well and you trust, it's easy to fall into that trap. So thank you for that reminder. And then the last question I've got is actually about something not on your report, but I've had a number of employees contact me about that HSA Bank investment portal switch I think sometime this year we switched from one company to Schwab, and now I think it's just passed, but on September 24th, they've now introduced their own version of investments that cost change. I'm wondering, has staff had a lot of feedback about that? Because I've had a few, but I'm just wondering what kind of due diligence did HSA Bank allow us on that contract switch again? And, you know, and then there's been a change in the costs of investing with them. They've introduced some new fees that they themselves are charging. So I'm just wondering about that, all of that switch.
So this is Celestina Glover for the record. I've heard a little bit of feedback, but not a lot from members on the HSA Bank. You know, typically whenever they're getting ready to do something, we ask them if there's going to be a campaign or something that they let us know in advance, and we look at the documentation that's going out. But their business decisions, we really don't have a lot of say in. So the only thing I can really do is I can attempt to get an HSA I can get an HSA rep here for a future board meeting and have them speak to that directly so they can answer your questions after.
I think that would be helpful, because I'll be honest with you that you know, I did reach out to PEB and with a list of questions, and Jessica, thank you, Jessica, worked really hard to get the responses for me. But then I've got to tell you that every time you call HSA Bank, the customer service agents actually tell you something different. And so some of the answers Jessica gave me, which I probably trust more than the customer service, but they're giving different answers. And I can certainly give more specifics on that, but it's just a concern when it's, you know, when you ask a question, you want someone to give you, you know, a specific and correct answer. And that does not seem to be the case with this transition, and it's finance stuff. So it's all regulated. They can't just, you know, they shouldn't just be making it up as they go. But I feel like I'm getting a lot of contrary answers. I'll leave it at that. But I appreciate that. So I think that it would be helpful to hear from them about that switch, and maybe also the migration, because there was they were mapping people, which is the automatic movement of monies, and then they were also allowing people to stay invested in one option and not in another. There's lots of moving parts to it, I think, is what concerns me the most. Thank you.
Any further questions? Okay. We will go ahead and close agenda item number 5 and move on to agenda item number 6, plan design report, Celestina Glover, Executive Officer, and Siegel for possible action.
This is Celestina Glover for the record. As I mentioned in the previous report, the first item on the plan design discussion is the budget status. As I've said, we had the $24 million shortfall going into plan year 24, and that worked out to a $43 million shortfall going into plan year 25. So those are things we need to consider moving forward, is what monies do we have on hand? And what do we foresee being provided during the legislative session? So I wanted to tee it up with where we're sitting right now and provide some level of understanding as to why some of the recommendations are being made in the plan design considerations. So one of the things we did take into account with our benefits are to get our life insurance back to $25,000 for active employees and $12,500 for retirees. Those amounts were reduced due to budget constraints, which is typical of what happens. I wish it wasn't the case, but it is. The legislature, however, did provide some general funds that funded the portion that we reduced. So we have been offering the 25 and 12.5 for these last 2 years, but I want to make sure it is part of our budget and not asking them for general funds. Because we typically don't receive general funds, at the end of the year, those general funds are reverted, so it can cause a bit of a nightmare to try to figure out how much of that money did we really use in our life insurance payments. So having it, I would like to see our benefits stabilized and not hit every time we have a budget issue. It's just a matter of who pays for the benefits, because it's a combination of the employer and the employee. And if the employer isn't willing to provide the contributions we need, then that is on the backs of the employees and the retirees. So that is something that's always in the back of our mind when we make any recommendations or suggestions, or we start looking at what our options are. So that's just one of the things that we are looking at when we do this. The consumer-driven health plan has been our primary plan since, I think, 2012, I want to say. I'm not even for sure. And that is the plan that was introduced to allow us to offer health savings accounts and health reimbursement arrangements for our members. The ability to provide the HSA funds, health savings account funds, is to ensure that we are at the minimum level required by IRS for the deductibles for a single person and a family. Those deductibles are going up to $1,650 for self-only coverage and $3,300 for family coverage, which is a $50 increase for the single person and a $100 increase for the family. We have no control over that. As long as the board wishes to offer an HSA, we have to meet that requirement. So we have always historically stayed at the lower end of the deductible to ensure that our plan is in compliance. We have made no changes to the out-of-pocket max. We've kept that at a fairly low level compared to what the IRS allows us to do. So we continue to try to maintain that. Once we get to a point where our out-of-pocket starts to fall below what they say we can do, they have a max versus a minimum, then we'll look at adjusting those. But right now we're still in safe territory. As people have said, we are able to raise the contributions members can make toward their HSA accounts. But it's kind of offset with the cost of the deductible, but it doesn't make sense. Leave the deductible at 1,600 and the contribution where it's been, or raise it and raise the other to go with it. So you have to ask the IRS why they make the decisions they make, but we are going to keep our plans in compliance until such time as the board decides that they no longer want to offer an HSA option. We have, the HSA was another one of those things where the primary, their contribution was reduced to $600. And we eliminated contributions to family members. We did receive additional funding from the legislature to supplement some of that funding. Again, the drawback with the general fund, having to revert it, we revert those funds. We keep whatever was technically put into the HRA accounts, but that's not, the HRA accounts aren't real money until the individual actually files a claim on those monies. Well, they have a year to file their initial claim, and then any balances they have carry forward. Well, the general fund doesn't carry forward with it. So we're in this position that if they use their entire balance in the year they were given it, we're fine. But most people don't. They carry over some amount, whether it's $50 or $600, they carry over something. We have a lot of people that we term savers. They're saving that dollar amount for a bigger ticket healthcare item versus the smaller copays and deductibles or whatever that they may incur during the year. So we have a mix of people. We have some people that they choose not to use their HRA funds because there's a requirement to submit receipts to prove that you went to the dentist or you went to the doctor or whatever. And that again is an IRS requirement. And some don't want to go through that. They feel that that's a hassle. So they don't use their funds in any way, shape, or form. So those balances sit there. But we have to treat it as if at some point, until that person leaves the plan altogether, that they may access those funds. So my proposal in the budget took everything back to the $700 for the primary and back to the $200 for dependents, up to 3 dependents. Whether or not that will get through GFO and the legislature, I don't know that at this point. So it is built into the budget to kind of restore some of our benefits to the levels they were prior to COVID. The new plan, which we've had for a couple of years now, the low deductible preferred provider option, that one did have a deductible at one time. My understanding, and this occurred before I came back to PEB, is that the legislature decided to remove the deductible. It wasn't a PEB decision or PEB board decision. So there is language in there of co-insurance. So 80-20 is typically what we set our co-insurance at. There's also copay language in there. So some visits have a copay, $50 or whatever it might be. Some are, the member pays 20%, the plan pays 80%. And I understand that can be confusing. But depending on the decisions the board makes today, we will look at the payment structure in the low deductible. As you've heard, a lot of discussion about keeping the HMO, not keeping the HMO, and the EPO, and the cost around it, and the certainty of knowing what that payment is going to look like when you do go for your provider care visit. My proposal would be that we structure the payments in the low deductible to be a copay structure, not a co-insurance. So you always will know what that dollar amount is, whether it's a $30 doctor's visit or a $50 specialist or whatever is the appropriate amount. So it will look similar to what an HMO copay structure looks like, although it may be a different dollar amount than what we're seeing right now. And I propose that it becomes a traditional PPO without the deductible. So that would mean renaming it, because low deductible doesn't make sense if there is no deductible. But that is something for the board to decide. That takes me into the HMO EPO plan viability. So we have several issues there. Outside of just the cost of those plans. So we hear individuals saying that, you know, they're certain of their costs. And there's been some discussion of one plan costing more than the other as far as what they pay out of pocket. But keep in mind, the out of pocket is also your premium. And the premium payment on the HMO EPO combination plan is $100 more a month for a single person on the plan. So you got to take into account that $1,200 a year that you're paying out in addition to your co-pays. So when you say I go to the doctor 3 times and I had to pay $30, you paid $90 for doctor's visits. You may or may not have medications as a result of those visits, but you also have $100 a month on top of that. So you're $1,290 more. If the copay is very similar in the low deductible plan, but your premium is less, you're actually out of pocket for less. The also out of pocket max is less in the low deductible than it is in the EPO and the HMO plans. So those are all considerations that we looked at when these recommendations were made. We do have an RFP out right now. We have not received the responses yet. There is the possibility that we get several people or several companies submitting proposals. Historically, that's not the case. We generally get 2, maybe 3 from providers in the area. HPN, our current vendor, is usually one of our responders. But we don't know what that renewal is going to look like. So for budget purposes, we built the budget assuming that it's going to come in at the highest rate of the current contract. That contract expires on June 30th of 2025. So at the end of this current plan year. The timing for considering coming down to the 2 plans, the CDHP and the low deductible, if you're going to do it, you're not in the middle of a contract. So that is another consideration. The EPO is a self-funded plan, so that is a consideration the board can make at any point because the contracts that we have would be TPA, network, and things like that that we have for the other plans anyway. So it's working with the vendors for what those payment structures are going to look like for the existing plans. We did have double-digit increases for plan year 25 on the HMO. They came in at 12%, which was lower than we expected, but higher than we were hoping for. And again, it's related to what claims costs are. So we're looking at trend and experience, and what does that look like? We're seeing costs go up across the board on all the plans. So it's not unique to the HMO and the EPO, but the other 2 plans right now are costing us significantly less from a base plan structure for both the employer and the employee. So again, another consideration in our discussions on whether this makes sense to keep these plans. And then we are also seeing the migration from those plans into the low deductible. We're seeing a lot of migration from the HMO and the EPO to the low deductible plan. We are also seeing migration from the high deductible, but right now the high deductible plan still has our highest number of members. We're at about 11,900, maybe 12,000 employees and retirees in that plan. We're just over 11,000 in the low deductible. The the HMO has about 3,400 participants, and the EPO has about 2,600 participants currently enrolled. That's employees and retirees both. So between the two plans, we have about 10% of our total population, not including the exchange, 10% of our population enrolled in the HMO and 9% enrolled in the EPO. Those plans are going to be, they're essentially going to sunset themselves if we keep seeing the type of migration that we've seen over the last few years, because people are leaving those plans because although they may like the payment structure, a lot of people are going to opt for the other plan because the premium is lower. And that is out of pocket every month, regardless of whether you go see a provider or not. So another consideration when we looked at this, we are not looking at it strictly on a employer cost. We know we've set the structure for the contribution from the employer at a flat rate. But can we adjust that to make that, bring in the same dollar amount from the employer, but apply it to just the two plans versus three plans to maybe soften the premium? I don't know yet. That's an analysis we will have to do, and it will be dependent on what is approved during the legislature. So those are all considerations we discussed. I have Siegel here who have put together a presentation to talk about the comparison of the EPO and the HMO and to help answer questions. Keeping in mind that, you know, we have been talking about this. Laura Rich, who was this executive officer previously, had discussed the potential that at some point these plans would not be viable. I've continued that discussion, and we are now at a point that I think it's time for the board to look at it and to really consider whether this is the right time to make that decision. So with that, I turn it over to Siegel.
Okay, thank you.
All right, good morning. For the record, I'm Richard Ward with Siegel Consulting. We're the consultants and actuaries to PEB. And we have some materials here to review to continue the discussion that Executive Officer Glover just initiated. Our materials begin on page 67 of the board packet, 65 of 77 pages in the PDF, if that's a helpful reference point. And while we recognize there are a number of considerations, some objective, some subjective, some tangible, some intangible, and there's a range of perspectives for a consideration like this. And we acknowledge that those are important considerations in a decision such as this. The materials that we've provided for this discussion are more technical and financial in nature, but not intending to diminish the other considerations that are very important. It's just our contribution to this discussion so that the board can have this perspective when considering this decision. So on a little bit of background here. So we're on page 66 of the board packet, which is page 2 of our materials. Just a review of some of the metrics for the different plans. So we've got here across in the first row for the 4 plans, the actuarial value. Just as a refresher, the actuarial value is a reflection of the total costs that are paid on average by the plan, with the balance being paid by the member. So looking at the CDHP plan that has an actuarial value of 76.7, and what that indicates is that the plan pays, let's just call it 77%. 77% of total cost of care, with the members paying the balance, 23% in deductibles, co-pays, and coinsurance. And that's on average. Members, depending on their utilization and needs, will experience different levels of cost sharing, some more, some less, but that's a measure of the overall value that the plan provides on average. And the CDHP plan having the lowest premium, the premiums for employee-only coverage are shown in the bottom row. And then some highlights of different some of the main plan provisions are shown in between, deductibles, maximum out-of-pocket, some co-insurance, some key copay levels, and pharmacy cost share. The low deductible health plan has a richer benefit design and also the next highest premium. So there's about a $30 difference in the monthly premium for single coverage. And the actuarial value is about 8 points different. So what that means is that for every $1,000 of healthcare costs, the members are paying $80 less, or their share is $80 less, and the plan is paying an additional $80. And then we have the EPO and the HMO, and the EPO, the actuarial value is really not that different. The plan value is about 3 percentage points different from the PPO. So it is a richer plan, and the costs and the premiums are for the employees are higher. And as Executive Officer Glover was mentioning, the difference in the premiums is greater than the difference in the maximum exposure or the maximum out of pocket per member for the year. So in particular, in the middle, there's a row for the out of pocket maximum. And just looking at the low deductible and the EPO on the individual basis, there's $1,000 difference. And then Executive Officer Glover noted that the difference in the premiums is almost $100 a month, so almost $1,200 for the year. So members that are choosing the EPO and the HMO, or choosing the EPO, let's just stick with that, are paying $1,200 roughly more a year for $1,000 less in maximum exposure. So you're actually paying more than you're getting in return. And I think that's an important consideration here, and just how the balance or the comparison in the value to what members pay to get into these plans. And then you have a similar differential for the HMO as well. There's a $1,000 difference in the maximum out of pocket. And because the two plans are blended together, the premium is the same from the employee's perspective or from the member's perspective. And so you have that same differential of about $1,200 versus $1,000. Moving on to the next slide. At the last meeting, we reviewed a concept that we refer to as plan efficiency. And I thought it would be helpful just to review that again in the context of this discussion. And I won't revisit all of the detail that goes into determining plan efficiency, but what plan efficiency is a measurement of how well a plan manages the cost and health risk that for the membership covered in that plan. So as we're looking at the EPO, which has higher cost share, has higher premiums, has higher costs, and we saw that it has higher health risk. How does that really compare against the CDHP? So is the CDHP lower cost just because all the healthy people are in it? Or is one of these plans managing health risk better than the others? But that's just a combination of plan design, incentives, steerage, health management programs, and so the calculation for this metric is to take the PMPM costs per member per month dollar amounts and normalize for plan design. So the CDHP has lower plan costs partly because it has a leaner plan design. So let's level the playing field for plan design differences. And then let's also compare, let's incorporate the overall health risk for the members and normalize for that as well. So it's costs divided by plan design value actuarial value and divided by risk score. And the risk score is something that we determined using a set of risk factors that they're commonly used in the industry. And we reviewed the claims for every single member and then determined a risk factor based off of the claims activity and the care needs that they've had, the medications that they're on, the diagnoses codes that are indicated in their claims. So people that are diabetic have a higher health risk than those that aren't. So the more chronic conditions that we can see in the claims data, the higher the risk score. So with a higher risk score comes higher expected costs. So just looking at what the net measurement here of all of this is we think a helpful way to look at which plan is performing better, for want of a better characterization. And the lower the efficiency score, the more efficient it is. So what we see with this is that the low deductible plan, the low deductible PPO, has the lowest value for this measure. And I think that's to be expected, and the membership is recognizing that as well with the migration from the other two plans into the low deductible health plan. So it's providing the best value to PEB, and by PEB, I mean the plan as well as the members. And here's a couple of slides that we reviewed at the last meeting. So moving on to page 4 of our materials, just looking at the historical costs. This is on a per member basis, PMPM per member per month. And the green is the EPO. So it's been the highest cost plan over the last couple of years. And then the three lines at the bottom, you have in order from top to bottom, you have the HMO, which is based off of premiums. You have the low deductible health plan in orange, for those of you with color printouts and slides. And then the CDHP is the bottom one in that lighter blue. And then the one in the second one from the top in kind of a darker purple or blue, that's the blend between the EPO and the HMO. So the HMO has been historically lower cost than the EPO. And then when we blend them together, we still get the highest cost plan out of the 3 plan options. Moving on to the next slide on page 5. Again, a little more historical perspective here. So Executive Officer Glover talked about the HMO and the recent renewals. So in the current contract, there were premium increases for plan year 23 and 24 that were capped at 9%. And each of those 2 years, the renewal came in at 9%. And the costs that were being reported, that we were seeing, that were being experienced by Health Plan of Nevada were substantially higher than that 9%. So this is an unusual situation from our perspective as in our role with our clients. Usually we're able to negotiate with our clients' insurers when they have insured plans, but there really was nothing to negotiate because the costs were substantially higher than the cap. And so for plan year 25, I recall about a year ago being here and having a discussion about the cap for the last year of the contract being 20%, not 9% as it was for the prior 2 years. And costs were expected to be above that 20%. And we'd have a similar situation, just that the cap was substantially higher. So we're all prepared and braced for a 20% increase. And the costs in the renewal supported that, would have supported that from our perspective. Costs were 29% above the current premium. And Health Plan of Nevada's renewal proposal was, as Executive Officer Glover noted, was about 12%, which when you're prepared for 20% is good news, but 12% in other situations is very challenging. We're typically working towards mid-single digit proposal, mid-single digit renewals, 5, 6, 7%. Once you start to get near 10, then that is very concerning. So just from perspective, we were expecting 20, we felt good about 12, but really, as Executive Officer Glover noted, 12% is pretty high. And so premiums are lagging expenses by 17%. So there's, from our perspective, this 17% pent up increase that is not reflected in the current premiums. And over the longer term, we would expect that, I'm moving on to the next slide here. We would expect that to be reflected in the premiums. Maybe not next year, maybe gradually over the next couple of years, but no insurance carrier or combination of carriers is going to subsidize the costs for a plan over the long haul. They just financially can't do it. And so we expect that the HMO is going to increase at a fairly high trend rate. And this is smoothed out. It may happen all in 1 year with the RFP. It may happen gradually, but it'll be above trend. And we expect that for plan year 23, we'll no longer be in a position where with the current 3 plans, the 3 current options, that the HMO is going to be subsidizing the EPO. Those costs will catch up to the EPO. And you can see those lines converge at in the top, that top point there. And again, this is on a per member basis, but the costs for the combined plan will go from about $690 to about $1,403, $1,400 as we're expecting. So about a $600 difference between that and the CDHP. And if you think about it from an employee premium perspective, the CDHP, the single premium is a little bit less than 10% of the total cost. And so if the CDHP is at about, let's say it's in the $80 to $100 range, just some rough figures. Again, we're forecasting several years into the future here. We don't know what the AGIS and the RGGI and the state funding is going to be. We don't know a number of things that will be determined over this 6-year period. But with the current approach where the same funding is applied to all plans, that means the premium for the EPO HMO will be about $600 higher than it is for the CDHP. So it's whether it's $600 or maybe something a little bit less or a little bit more, it'll be substantially greater than it is now. Now, a little more historic perspective, just a review of the premiums for the plans. These are the same slides that were in the July board meeting packet. It's really just for reference and context and perspective here in the moment. The EPO has been the highest premium plan, and it's about 2 times the premiums for the low deductible health plan and about 3 times the CDHP premiums. And these are just the single employee premiums. We've reviewed migration. I think we're all familiar with the migration from the CDHP and the EPO to the low deductible health plan and the HMO as well. We're seeing the HMO enrollment decline, maybe a little more gradually than in the other plans, but that's contributing to the increased membership in the low deductible health plan. And trying to get my own slides to advance here. Okay, so now I'm on page 9 of our materials, which is page 73 of the board packet. And what we have here in the top right is a projection of total plan costs for state employees. We just simplified the analysis here, but the implications and the general concept is applicable to PEB from a broader perspective. So over this 6-year period, we're projecting plan costs to increase from about 460 million to about 625 million for the current program. And without the EPO and the HMO, that those costs would be lower. The initial reduction would be about 5 million, and then that gap, that differential will grow over the 6-year period to a difference of about 30 million for plan year 30. And so eliminating the EPO and the HMO will reduce overall plan costs. And that's for both PEB and the member. And that results in savings of about, let's just say $40 to $50 PEPM for plan year 30. And that is for every member in the plan, not just those that are not just for the EPO. That is spread over the entire membership. So it reduces the cost for everybody. The savings come from, well, there's going to be a difference in plan design. These are the two richest plans. So there is a plan design savings component to this. There's also retention and administration costs. So the HMO right now has retention of about 17%. So if the premium, it's not $100, but if the premium is $100, $87 is going to claims costs, $83, excuse me, is going to claims costs, and 17% is going to everything else. That's risk margin, that's profit margin, that's admin, and the margin for the self-insured plans is more in the 3 to 4% range. So there's savings there. Right now, it's unclear to what extent pharmacy rebates are incorporated into the premium for the HMO. They're fully recognized and passed through and received by PEB for the self-insured plans. So we expect there to be some savings there. There's reduced trend for the HMO. We're expecting, there's that 19% pent-up demand for the HMO. And there are some cost increases. So the HMO does have a more, let's call it hands-on style and health and care management. And there's less of that in the self-insured plan. So there might be a little bit of an increase in costs due to that less aggressive managed approach to managed care. And from discussions with UMR, we understand that there's a slight difference in provider costs. So the provider contracts pay a little bit more in the self-insured plans than they do in the HMO. So there's less capitation, maybe less bundle payment agreements in those contracts. And so the costs are a little bit higher. But when you bundle all that, let me use a different term. When you put all that together, there is an expected net savings to PEB. And again, that's the plan and the members. I think one last slide here. It's challenging to estimate the employee premium impact. There's a number of factors that are yet to be determined. One of which is what funding is going to be provided to PEB. What is the AGIS and the RGGI, or what are the AGIS and RGGI going to be for the next biennium? We don't know that yet. There's some other final plan design considerations to be discussed. And then once we see what the funding is and final plan design, what do we think the migration and the risk selection might be to the low deductible health plan and to the CDH. But we did some rough estimates here, and we have to acknowledge that the costs of the EPO and the HMO membership are higher for those members than for the people currently in the other two plans. And that's reflected in the premium differential. So those members going to those two plans will raise the cost for those two plans. And we expect that may be reflected in the premium. And so there will be higher premiums for the CDHP, we think, and the low deductible health plan. But that's subject to funding and the AGIS and the RGGI and the decisions that y'all make about what those premiums are going to be. And so for just next steps, We have a couple of things here. We've talked, Executive Officer Glover talked about reviewing the plan design and the low deductible health plan. That's something to undertake. And then also this would result in several thousand members being added to the self-insured plans. So we would expect there's an opportunity to negotiate the pricing guarantees in the pharmacy contract due to the increased membership. So that's something that can be accounted for in the next cycle with the next market check. And I think that's our last slide. And slide at our own peril, I suppose, slide 11 invites questions.
Hey, any questions?
I have a bunch of questions. I also don't want to monopolize, and so I'm happy for everyone else to go first. I do, but one specific question I have that I've been curious about for a long time around the actuarial analysis. So going all the way back to slide 1, which is the current plan design and premiums. You know, you've given an actuarial value of each of the plans. Does this actuarial value include all of the cash givebacks from the last legislative session and previously? So there was HRA, HSA, deductible minimization. So this is a true reflection of all of the money that's gone into the plan, not just the PEB revenue. It also includes the general revenue.
It's a reflection of the benefit design.
Okay.
So it's not the revenue or the funding. So
But the plan design changed when we got more HSA and HRA money.
Right, that's
The only
reflected.
yeah, because I asked this.
That is
because-
reflected in here.
Okay, so, okay.
This is not a complete summary, and I suppose maybe for space, we did not include HRA, HSA allocations, but all of that is accounted for in this determination. And it is a bit of a moving target because when you're determining actuarial value, you can use a model that estimates what the average cost share would be, but then you can also look at claims data. And when you have claims data, you can really you can just total up, what did the members pay? What did the plan pay? And that's the number, but that's going to change a little bit from year to year, just because utilization and costs will vary a bit from year to year. It's not it's not quite as precise as maybe we're indicating here with a decimal point. So I would say review these with a grain of salt, and that we're really interested in the relativities between them rather than the precise numbers.
Yeah.
But in the ACA parlance, 3 of these plans are platinum plans, or the 3 on the right, and the CDHP plan is a gold plan.
No one else is gonna go. I'll keep going.
Any other questions?
It's kind
You
of
wanna
like
come
a
sit down
threat
here?
almost.
Do you want me to jump in just to break it
Yes.
up a little bit? Okay. Jennifer McClendon for the record. These are questions that I have that I don't think can be answered today, but one of the issues I've been thinking about is less about the impact of this. Clearly, this change would have a good financial impact on PEB over the long run, and then that in turn helps the members who are paying to fund PEB. However, I'm just wondering if there's a way that we could visualize the impact of losing the HMO or the EPO for like an exemplar family that is on the plan, right? So if we could look at a family that's on this plan that has very high health costs, moderate health costs, and low health costs, so that we could see this family, families with high health costs are on average paying $2,500 out of pocket, not including their premiums, right? Because then we can do that math later, but per year to pay for their child's cancer treatments or to pay for a spouse with a substance abuse issue or whatever that might be. And then if they were changed over to
what we now call the low deductible plan, what would their out-of-pocket expenses be? Like, I just think it would be helpful to see what the difference would be for an example family, if that makes sense. Is that possible? Is that something that we could get, or?
I can
Or do you
respond to
have
that verbally
yeah,
right now, actually.
Please do, that'd be helpful, thank you.
So let's, Richard Ward from Siegel for the record. On page 2, this will be maybe more simplistically than you're envisioning because I'm doing it verbally. The difference in the family maximum out of pocket. So the high cost, so the family that has higher needs. So let's just assume that that family hits their maximum out of pocket. So in the HMO, they have $10,000 a year that they are paying out of pocket.
Yes.
In addition to that, they're paying a difference in the premium. They're paying $651 a month in premium. If they go to the low deductible health plan, that 10,000 becomes 8. Let's just say they continue to max out. That 651 becomes 423. And so their out-of-pocket costs go down by $2,000. And their premiums also go down.
Right, so if I could ask a follow-up question, again, this is Jennifer McClendon for the record. Do we know how many folks max out on each of these plans every year? Do we have a way of getting that data? Or how close people are to maxing out on these plans? Like, are 80% of the people who have HMO or EPO coverage, are 80% of them within $500 of maxing out every year? Like, I'm trying to get a sense of where people are at in these.
We can certainly get that. The next example that I had was anybody that has more moderate needs. So they're not maxing out, but they're lower. They're having lower out-of-pocket costs. Their costs generally go down as well. And they're paying a substantially lower premium.
If I could follow up with just one last quick comment, I think it would be very helpful to have a visual for that, because I understand the panic of someone who's a member thinking, I know what to expect. I can see from this math that it probably is going to be a win for most people, but I'd also like to know maybe who it wouldn't be a win for, so that we can make this decision with some compassion for families that might be in very specific health situations that would struggle in ways that we can't see just from looking at the averages. So that's my 2 cents, and I'm done. Thank you.
Yeah, this is Betsy Strasberg. I think, I have a finance background, and this is very, very convincing to me, but I think it's more important to satisfy the concerns of the many people who came here to do their public comment, and some visual of taking some scenarios and having that communication with them would be very, very helpful. Because irrespective of the map, it's the emotional impact of a change from 3 options to 2 options. And I think we need to be cognizant of that.
Can I just add on to Janelle Woodward for the record? So one thing, and correct me if I'm wrong on this, but I made that change from the EPO to the low deductible. And one thing that I've noticed is that your medication costs go towards your out-of-pocket with low deductible, but they don't do that for the EPO. So even with high costs for myself, I didn't meet the out-of-pocket for the EPO. And I kind of feel like I might on the other one, and I've had to make that change in the past from previous jobs. where they made the choice to take away that. I am not saying it's easy or not scary or whatever, but I think that your idea of the visual is so important because that does show somebody who's in that situation where they're an HMO and that's what they're used to. What would be the, you know, the result of making that change? And then they maybe are more comfortable with if that's the choice that is made. Thanks.
Michelle Kelly for the record. So starting just at the global position, you know, as we heard during public comment, I think some of the institutions, so I represent NC South, and some of the institutions in the South sent around, I think actually one institution in the South sent around an email on Tuesday, which is in the morning, just saying, hey, heads up, there's this agenda item. And I think that there was another communication go to a limited number of people at all of the other institutions. And just so personally, beginning on Tuesday, I've received around 43 emails that were directed specifically to me, and mostly from people in the South. And I would tell you that that's an unprecedented number of emails from a very limited group of people, because obviously the state has many more employees in the South that maybe don't go out and check the PEB board materials on a bi-monthly basis. I wish they would, because I think getting that specific feedback from participants is so helpful, you know, when we're talking about things like this. And so, as I say, 43, I've never had that many emails. I actually felt like it was more, because then I was thinking, how do I respond to all? Sorry, people. If I haven't got back to you yet, I will. And so the concern kind of fell into two categories. I think, you know, overwhelmingly, what I was hearing from people was that they like the predictability of the costs in the HMO. We heard verbally that people don't mind paying more per month because it's their risk mitigation strategy is to pay for it monthly, so that they know what it'll cost if they have to take their child to the emergency room. It's going to cost them $600. And I understand that the PEB, the way the PPOs bill, you just need to be in a PPO once. And if you're a very conservative person, you run screaming, right? The billing is just off the charts. The way the hospital tells you what it's going to cost, and they go, we don't care about the contracts. You're on the hook for, you know, $100,000. They may, at Renown, they make you sign for that amount before they even apply any of the contracted. So using a PPO is very confronting for people. So there's that aspect of the HMO and the EPO. I think the other aspect is just that disruption, right? From participants, we heard people have had years of relationships with their doctors, their therapists, and they don't want to lose that. Obviously, we can never guarantee that anyway, because we've heard about the Carson Tahoe, but there's that issue as well. And so on a very global level, I think I think that this actuarial analysis, I appreciate all the work that goes into it, and I understand, I guess, the theoretical nature of this. But health insurance is more than theoretical, right? So much of health insurance is emotional, about how you want to pay for things. It's kind of understanding your own personal risk, what you can tolerate. And so for many of the people I got public comments from, they talked about how as a sole parent responsible for multiple children, there was no way they would be able to do the PPO. You know, there was other people with their own chronic illnesses who just didn't think that they could work with the PPO. And so that's what I heard from participants. And I think structurally, for me, I've been at NSHE way too long, but I was at NSHE when PEB reduced the plans from 3 to 2. You know, and state employees and NSHE employees worked so hard to get the choices back to 3. And so just a few years later, now we're talking about taking it back to 2. And I see the very long term, there's a huge amount of money we're talking about. In the short term, honestly, it doesn't really seem like a lot of money. And then when I start to try and identify the costs between EPO and HMO, it becomes even more murky, right? Obviously, everyone I heard from is in the South. So I don't want to minimize the impact that the EPO has on people in the North. But certainly in the South, people have been paying for an HMO, and they've been paying a lot for the HMO compared to its cost. Now we're talking about the HMO maybe having to kind of catch up a little bit, and we're talking about removing that benefit from them. And I think, like, from just a human perspective, I think that as a board member, I am very challenged by that thought. And now I'm going to get to my questions, I promise. So I was kind of interested. So some of these slides, I'm sorry, your slide numbers aren't actually, they don't have a number on them, but I want to go to this.
I'm sorry.
They do on mine.
Oh, they do. Okay, so HMO.
And I'm in the board packet.
I'm in the board packet, but mine doesn't have page numbers. So HMO increases have been capped is the title of the slide.
Okay.
I'm really challenged by some of the data on this. I want to understand how Siegel is saying that, that there was a 29% increase in costs. The contract calls for, I understand the contract called for a maximum of a 20% cost increase for fiscal year 2025. But then HBN came in with a 12% increase.
Mm-hmm.
Isn't the fact that the necessary premium renewal should have been 29%, firstly, isn't that theoretical and irrelevant? Because it wasn't.
Trying to think of the best point of entry to respond to that. The 29%, first of all, is this is Richard Ward for the record. That it's not a 29% increase. It's that the expected cost levels are 29% higher than the current premium. So that's let me say it a different way. Costs were already above the premiums. The 9% caps that the cap on the premium increase of 9% was resulting in the premiums lagging expenses by a considerable amount. So cost didn't go from parity with the premiums to 29% higher all in 1 year. They were already up there. So when we were approaching plan year 25, the renewal, the projection for claims costs was 29% higher than the current plan year 24 premium. So for that, so there's 29% to catch up, if you will. But there was a 20% cap. So we expected a 20% increase, which would still leave a 9% gap to be dealt with at some point. Instead, the health plan of Nevada proposed a roughly 12% increase, which was surprising.
And so how did they it's Michelle Kelly for the record, I guess that was a very long way of saying, to me, it's still kind of irrelevant, right? Because HPN came in at 12% increase. So how do you reconcile that?
Well, we don't have line of sight into their inner workings as a business. But I will speculate that the pharmacy rebates, among maybe some other revenue streams that have been profit for them, were used to offset that increase.
Okay, so
They made a business decision.
They made a business decision.
And all I can do is speculate.
And
I'm sitting here with somebody from, that could perhaps comment more directly than I can.
Right, but so I guess what I'm hearing is that maybe there's money out there that they're receiving that they use that is part of the plan design that you didn't account for, but that pulled the cost down.
Historically, they haven't shared it, so.
Okay, so we're missing data. potentially?
That we would commonly not get. I
Okay,
mean, we're just not gonna get it.
that's okay, but we're missing it. So we're not looking at a full picture here.
Right, in a self-insured environment, we would know all the revenue streams and we would know what the pharmacy rebates are. We would know what the admin costs are in an insured arrangement. You're only gonna know so much.
And I'm asking hard questions, but it's not directed at you.
I understand.
I understand you're,
I'm
you're
giving you
doing
the
best
best
you
answer
can.
that I
Yeah,
can
with
from
the data
from our
you've got.
perspective and acknowledge that if even though I'm sitting across the table from you, we're actually on your side of the table.
Yeah, I get
In this whole consideration.
But so right now we have an RFP out in the market. And so that's also another data point that we don't know what, because we don't even know all the income sources they have. And one would have to assume that just like our self plans get rebates, that hopefully the HMOs do, because otherwise they're missing out apparently. But so we do have an RFP out there that could illuminate this issue more for us about what the actual costs are going to be. Because I guess I keep coming back to, obviously I was not born and raised in Nevada. And I was lucky enough to come from a country that has, where I didn't have to know about health insurance. That's the reality of living in a country that has, universal healthcare, is that it's not that it's cheaper, better, different. It's just, you don't have to know. And I've got to tell you, there's a beauty to that.
Half of my family is Canadian, and so I am told on a regular basis how much better and how superior that is.
And it's because you don't have to know, right? We all have to know. And so, but
I do
guess
share the weather though. I live in San Diego, so I usually share the weather with them when we have these discussions.
Yeah, but when I moved to this country, I was on obviously a really steep learning curve. That's kind of where I was going with this. And so, and my very first job was in health insurance. So go figure, right? But so I always come back to the foundations of, for me, the difference between the plans, right? Some of it, and that now I work in retirement. So you're understanding your own risk profile is such an important aspect of living in the United States, for retirement, for health insurance.
Yeah.
And many people choose the HMO specifically for that risk minimization. And I hear Executive Officer Glover, I appreciate that you want to look at, the PPO, whatever we're going to call it, the PPO plan down the line. But I think that for me, I think for transparency purposes, we should be looking at it at both issues together. We can't, I don't personally want to make a decision on the HMO, and incorporating into my decision process the thought that down the line we can turn the PPO into more of an HMO, but then that never eventuates. And so then we just have two plan options that PPO and people have co-insurance that, and the max out of pockets are fantastic on the PPOs. That they really are great max out of pockets. People are protected. The problem is that many people can't walk into an emergency room and flick out a credit card and pay the first $10,000 of treatment for their child. And that's a huge issue for all of our employees. And I think I've taken the mic enough. I think for me, that's where I end up. I think we need more data. I think I can't in good conscience vote to remove the HMO at this point after hearing from all of our participants and truly not understanding what the RFP might show. We could get a statewide network and not exploring other options like separating the EPO and the HMO out. And so I think for me, it's a limitation because I kind of need to see the whole picture so that I can understand both from an emotional perspective, but also from that risk minimization or the risk profile to make sure our employees get what they need from health insurance. Because every time we take away a plan, we're taking away morale, and we're losing some employees. Employees are actively saying they can't stay, and that's a problem for me.
So this is Celestina Glover for the record. So a couple of points of clarification and some history. I'm not proposing we make the LD PPO act like an HMO. I'm simply suggesting that we consider permanently eliminating the deductible portion if we eliminate these other two plans. I'm also suggesting that we consider taking the language for co-insurance out and making it all a co-pay structure, whatever those dollar amounts look like. So that would give our members a level of confidence of knowing if they're going to the emergency room, it's $600 or it's $50 to see a specialist or whatever those dollar amounts should look like. So not saying it's going to look like an HMO because it's not. The other thing, as far as the EPO and the HMO with the blended rates, the reason that was done years ago, we had two HMO plans, one of which acted more like a PPO than it did an HMO, a traditional HMO. There was a certain level of concern that if those rates weren't blended, the HMO in the north was significantly more expensive than the HMO in the south. And so to keep all the employees that were at the same level of pay, if there's a single person on the plan, they all paid whatever the dollar amount was. If it was $100 a month, they all paid $100. We didn't have the group in the north paying $120 and the group in the south paying $80 for essentially a similar plan. So there was some level of equity considered. So that is how we got to the blending, and that decision was made before my time. I just want the board members to understand that. And also what I said earlier, we are getting to a point, a critical point in enrollment where the enrollment numbers themselves will not sustain those plans. I looked at enrollment that we're projecting for plan year 26. In the retiree group, I'm looking at 100 retirees on the non-state group in the HMO plan, and a similar number, actually less than that in the EPO, and about 260 in the NOR or in the HMO for the state retirees, and less than that in the EPO. So just the retiree group, we're talking about roughly 300, 350 retirees in those plans. So those numbers, they're already making the moves. They're already moving into the other plans. It's the employees. As I said, we have roughly 2,500 right now. We're looking at that number going down to about 2,200 in the EPO. I've got about 3,500 in the HMO. I'm looking at that number potentially going down to 3,200. There's been a lot of talk about how many people are losing those plans. I know we've had a lot of comments from UNLV and some of the other education systems down south, and they really only make up about 12 to 15% of the total HMO enrollment. So it's really the other members, the state members, and based on the information that Siegel has provided for us and the information I have tried to put together, the one example of the out-of-pocket, so somebody who maxes out, if they're paying $8,000 as their family out-of-pocket, that's a $2,000 savings. Their premium savings right now in the current plan year is a little over $2,700. So they're saving $4,700 over the course of a year, because once they hit their max out-of-pocket, of course, the plan picks up 100%. So there is a safety net regardless of the plan. Each of them have a max out-of-pocket for a single person and a family, where the plan will pick up. And the comment about the cost of your medications going towards your out-of-pocket. That is true on the low deductible and high deductible plans. That's part of the accumulator. It goes toward the deductible and the high deductible plan. So all those things are considered. So another place where you may be, if you have a lot of high cost medications, you may be hitting those out-of-pocket max even quicker than you expect, simply because you have high cost drugs to go along with your medical care. So, and the one question that we were asked was how many people hit their out-of-pocket and how many people don't. I would say that I don't have exact data, and that is something we can look to see how many people actually hit those numbers. But the higher users of the plan probably don't hit their max out of pocket. They're probably somewhere in the middle. They're not the, I go in once a year to see my doctor person. They're I go in a couple of times a year and I have some medications I have to take. Those are probably what we see more consistently. And then it's episodic care. Something comes up that drives them to the hospital, drives them to a specialist, whatever that case is. But ideally, that's taken care of, and they don't do it year after year. It's not a chronic condition that may cause them to reach their max out of pocket. So, but we can look at those numbers to see what percentage of our population actually stays somewhere in the middle, which percentage actually hits their out of pocket max.
FC Strasburg, Director Glover, can you share with us whether this decision of reducing the number of plans, whether we have some options on making that decision today versus the November meeting when we may have that communication done with the members as well as the RFP information coming in? And maybe, you can't share with us, but maybe with your discussions with the state, you may have a better idea of what the budget might look like and what the state can assist in this manner. Can you share your understanding?
Yes, this is Celestina Glover for the record. So the board can choose to delay the decisions. I would say probably the only one that you could make now with no concern would be the life insurance, the health savings accounts, and then table the low deductible EPO and HMO discussions for November. But at the November meeting, we have to have final decisions. We can't delay it beyond that because we're running up against time to set rates for whatever those plans look like. We won't know what GovRec looks like until probably the end of December, maybe early January. So I won't know where we are with the Aegis and Reggie request. I know what I've asked for, whether I get it or not. That's always a different ball game. And then as far as the RFP goes, we'll have the result of the RFP. The evaluation committee will have picked a vendor prior to the November board meeting. That meeting, when we talk about whoever wins that bid, will be a closed meeting. So the public will not be part of that discussion until such time as the board makes a decision to approve or not approve the contract itself. I won't see what the responses are. I will only see what the negotiation points are, because that's the only place I'm allowed to be involved in. I know that typically we have 1 or 2 board members on the evaluation committee, so those board members will know what the renewal rates are coming in at and who has responded, but they aren't at liberty to share that information. So, so those are things to consider. We're still going to be somewhat in a silo or in a, in a cloud of not knowing what all the information is. And the thing I want everybody to keep in mind too, with the HMO renewals, whether HPN wins the bid again for the South, we find one for North, we get 2 regions, whatever that might look like. If we got one that was statewide, that would replace the EPO and the HMO the way it sits now, because we wouldn't have the EPO on top of 2 HMOs. That would not be, that would be a nightmare for enrollment. So keep that in mind. The renewals may come in really good for the first year. The second year, they may blow up, and we won't know that until we get close to the second year and we start asking for renewal costs. So you run the risk of having to terminate a contract midterm. Because we typically go out for a 4-year contract, sometimes 5. So, you know, keep that in mind too, that you may have to make that decision to terminate an existing contract where this one's actually expiring. It's coming to its end through its natural course. So all of those are things to consider in addition to everything else that goes with this. And like I said, during my presentation of my report, we didn't go into this thinking, oh, PEB's going to save a lot of money. It really was looking at what is going on in these various plans. What do we believe is the best place that we can stage ourselves and our members to give them the best benefit package possible? And we can't grow benefits in the other plans when we're having to spread them out the way we are right now. Some don't make a difference. Life insurance is life insurance. It goes to everybody. But in other cases, if we want to lower co-pays or increase HSA and HRA money, if we don't get that funding from the employer side of the house, that means the members have to pay. So that stifles our ability to really look at benefits to make them stronger. And we get a lot of discussion about employees leaving state employment because they don't like the benefit structure, but our hands are tied when we have to spread out ourselves that thin. So that's another consideration. We are looking at retention and everything else that goes with it. So that's it for me.
Can I ask a couple of follow-up questions? So Michelle Kelly, for the record, I'm just, one of the questions I did have early in the session is, so the increase to life insurance, because of course the board made the difficult decision a couple of years ago to reduce that to 12.5. I think the legislature increased it again. Now you're going to build it into the base budget. What's the cost of that for the biennium? Of putting that back into the plan?
This is Celestina Glover for the record. I don't remember off the top of my head, but I want to say 2.5, 3 million a year. Somewhere in the $3 million a year range to get us back to those levels.
And I think I'm right in my recollection of how you stated this, but when you submitted to GovRec, you did that as part of the budget, but an enhancement. So it wasn't kind of, it was an add-on to, if it was $300 last year, it's 300 plus X this year for the life insurance.
This is Celestina Glover for the record. That's correct. We built the budget with the assumptions that things were going to reset. Part of my thought process was if the legislature was concerned about us making those cuts, and part of it was budget driven because, you know, we're given certain direction that we have to follow. It from a truly funding and administration, financial administration standpoint, it is much easier on my staff if we fund it from our own sources than having different funding sources. Because if this other funding source doesn't continue, we then drop the insurance again. And I would like to somehow, I don't know if I'll be successful, but get us to a point where the benefit structure is set at a certain amount, whatever the board thinks it should be. We will bring our recommendations, obviously, for the board's consideration, but we quit. This year it's 25,000. So somebody, sad to say, passes away, car accident, their family gets 25. The next person next year, their family gets 12,500. I would like us to hopefully get to a place where we can quit doing that. I can't guarantee it because, you know, some of that's beyond our control, but I would like to see our benefits stabilize to the point where we aren't constantly messing with those numbers. I was gonna say something else, but that we're not constantly adjusting those numbers, and our members don't know what their coverage is from year to year, because we keep changing it. So I would like us to get somewhat stable within the resources we have. And my plan is to make that argument to the GFO and to the money committees when I get to sit in front of them and make those arguments. So that's the hope, and that is my plan. Whether I'm successful or not, we shall see.
Well, personally, I appreciate your strategy because I think that's the best starting spot, right? I mean, you can only do what you can do, but certainly I think for all of our participants, we do hear that stability is so important. One last question and maybe a request. So talking about your idea of kind of changing the structure of the PPO, can you, and I apologize because I said kind of turning it into an HMO. Can you talk to me about what maybe, and to the public about how you see that working? So how is it still a PPO if we get rid of co-insurance? It's all co-pay based, I guess is where I'm challenged. And then my request, so I don't have to interrupt again, would be how early, if the board chose to table the HMO EPO decision until November, because we'd like to see kind of a chart of what it would all look like together. How early, or would we be able to get the documents for the plan design discussion earlier than a week before the meeting, so that our constituents could actually take a look at it and have time to consider it and think about it and ask questions and not just react?
Checking with my attorney, make sure I don't say something that is not accurate. What we can do, and Siegel, I'm about to give you a lot of work, and us too. What we can do is we can, with the information we have available as far as the HMO, it's not going to be specific to whoever the bidders are. So keep that in mind. Even if we're able to present you with those documents early, there's still going to be some gray area where the HMO is concerned. But we can look at what we have today, what the structure looks like, and do an analysis and present a report that says, if nothing changes, the HMO and the EPO are going to look like this. The low deductible will have some small deductible, and the payment structure will look similar to what it looks like now. But if we eliminate the HMO and the EPO, this is what the low deductible will look like. So you'll have the two. I'm not sure how early we can get that to you, but we will try to get that to you with enough time so that you have time to review those documents and maybe talk with your stakeholders in that case. So I don't want to put words in other people's mouths, but maybe 2 weeks out before the board meeting. That doesn't give us a lot of time. That's about 6 weeks from now, before the next board meeting. We're scheduled for 21st or 22nd, whatever that Thursday in November is. That is the time our next board meeting is scheduled. So it'd be about 2 weeks before that. Would be the earliest I would think. Can you do that?
We can do that. This is Richard Ward with Siegel. May I make another comment just regarding the terminology of PPO and EPO and HMO? Say PPO, preferred provider organization, I think primarily refers to the network structure. So you have preferred network providers and you have out-of-network providers. While they may commonly be associated with coinsurance, that's not necessarily a strict correlation. So you can have a PPO with copays. So it's more of a reference to the network structure rather than the benefit design. And then EPO, being an exclusive provider organization, means no out of network. And again, while that may often come with more of a copay driven design, that's not necessarily, that's not a requirement or doesn't necessarily need to happen.
And so just to follow up then, so when we're talking about getting rid of, putting words in your mouth, but when we're talking about the PPO and maybe a little bit of a redesign of the structure, we'd be looking at copays in the PPO portion. So the preferred providers, you'd have copays, and then if you wanted to go out of network, you'd have that ability, but it would be co-insurance and deductible.
It could,
Yeah.
It's an option. Yeah, this is
Right.
Celestina Glover for the record. So my proposal and recommendation would be if we didn't have the HMO, the EPO, that we make the PPO in or out of network a copay structure. The co-insurance really comes in because if you'll see the documents say 20% after deductible, but we have no deductible. So it's 20% after you pay nothing.
Still 20%.
It's still 20%. So if we, wherever that thing is, if we say like, medical co-insurance, 20% after deductible, well, if we call a primary care, specialist office visit 30 and 50, then we would look at that in the same way that, you wouldn't have a co-insurance at all. There would be no 80-20. It would be, it's $100, it's $50, it's $30, whatever the type of.
So you just be
visit is.
monetizing the percentages
Yes,
essentially, right?
yes.
I would recommend that there be a co-insurance provision for because I don't know that you can anticipate every single scenario and assign a copay in the plan document to it. So you may need and for everything else, which you may expect to be de minimis. But just from a plan design perspective, you'd want to, all right, and the attorney is agreeing. You'd want to have that just so that you can cover the waterfront more completely for every possible scenario for whatever care someone might need.
Celestina Glover for the record again, but things like, the emergency room visits, your standard doctor's visits, your specialist visits, those things can be co-pay. The things we know are pretty consistent can just be in a co-pay structure. And then like Richard said, the other items that are kind of outside what you typically expect to see, we can leave that 80-20. And that's going to be probably for situations that don't occur real often. It's not your regular, those mid-level people who use plans a lot, but they don't reach their out-of-pocket max.
And so just to delve into that, I'm sorry, Janelle, so you're talking hospital admission, we'd also have a copay though, right?
Yeah.
You always ask great questions. Janelle Woodward for the record. I just wanted to reiterate, I think, with an HMO or that type of plan, it's a pay as you go. And then you have your PPO where you're paying up front. So people they choose that, and I've been there. You choose that HMO because you're paying as you go, because a lot of people don't have that money up front to pay like you would in the CDHP plan. So I think it would be important to educate along the way on if the choice were to be made to sunset those programs, we're doing our best to make this as easy as possible, because you still are going to have people who just don't have that money up front to pay 20% before they can have something done. And you don't have that situation with an HMO, so.
So this is Celestina Glover for the record. So I'm going to reiterate this. If we don't have the HMO and the EPO for as many of the services that make sense, we are proposing we go to a copay. So it is a pay-as-you-go structure. And right now, based on the current options and what we know about the current HMO, that is what we'll use as our model for the reports that we come up with for the November meeting. So the low deductible, if it's already costing you less monthly, if the out-of-pocket max is a lower amount, so they're going to get 100% coverage sooner. Those are considerations, and yes, it's education to our members to understand those plans, but we can provide the information, but our hands are also tied that we are not licensed benefit specialists, so we can't be telling members which plans they should choose. So I can't tell you to enroll in this plan or that plan. I tell my kid that, but I probably wouldn't tell anybody else that. But having a payment structure reboot, so to speak, so that members will know, I'm going to see my doctor, it's X dollars. I'm going to the emergency room, it's X dollars, versus it's 20% of whatever that emergency room wants to charge me. That is what we're trying to address in the restructuring of payments in the low deductible plan, which at that point, if we go that route, I would propose we just call it the PPO plan, not the low deductible plan. And as Richard had brought up with the exclusive provider option, there is no out-of-network coverage in any way, shape, or form for the members on that plan. So in the other two plans, the low deductible and high deductible, if you go to an out-of-network provider, the plan still covers a portion of that. You will pay a higher amount out of pocket, but the plan will pay a portion of that. Same thing with medications. On the EPO, if a person goes out of network, they're on the hook 100%. There is no coverage from the plan. Same thing with drugs that are not in the formulary. They could potentially be on the hook for 100% of those meds. So those are other considerations, and we've seen that happen where somebody went out of network not understanding that their network is pretty restricted, and went out of state for care without getting prior authorization, and then they got billed for it. And then they were coming back to us asking us to fix it, but it's very clear in the documents, and we don't want people to get into that situation. So, and as much as we try to share the information and provide the documents, some people read it, some people don't, some understand it, some don't. We do the best we can to try to help them, and our partners with UMR and Siegel and HMOs, HPN, whoever they're talking with, they try to help as well, but the member doesn't call or doesn't read and doesn't let us know they're having an issue, we can't help. So.
FC Strasbourg, one last thought. I mean, we are already seeing migrations, but I'm hoping the ideal result would be with the information that you're going to provide before the next meeting, that people will take the trouble of looking at it, and that might accelerate the migration, and that's the best thing that we can hope for. Make our decision process more effective.
Just Jennifer McClendon, for the record, there's one other piece of information that would be helpful for me. And that's just listening to public comment about people who are worried about losing their providers, particularly in the South with the HMO. If we could just get, I've seen these before, but the network percentage coverage map thing, that'd be great. That's gonna look great in the minutes. I'm real excited.
This is Celestina Glover. One of the things, and this was a discussion I had with some stakeholders a couple of days ago. One of the things we typically do anyway is a disruption analysis to see how changes affect, even if we were going out to bid for a new network or TPA, we look at disruption analysis. And as part of that, we'll look at, can we get it more narrowed down? I think we've looked at it maybe holistically from a statewide perspective. But in my comment to the group at the time was, I'm not sure that we necessarily asked the right questions when we saw that. We said, oh yeah, we have 99% coverage, but we didn't necessarily say but not in Tonopah or not in, Pahrump or wherever we may have.
Where the entire 1% was every specialist of the state.
Yes.
In the state.
Whatever.
So, and that is one of the things that we've heard from public comment and that I've gotten emails about is that there are specialty providers who are covered under the HMO who are not covered under the other plans. And it sounds like we might have some flexibility to work on that. But
And
Maybe
we'll
helpful to
bring,
know.
this is Celestina Glover, we'll bring all that information back or as much of it as we can get together in this timeframe, because it does take a little bit of time to do a good analysis. Keeping in mind that we're still gonna have somewhat of a gray area for the HMO, because we won't know what those renewals are gonna look like for anybody who has actually submitted a bid, so we'll bring back whatever information we have available. But I will say this, regardless of what the board wants to do, the things I do need a vote on today is the health savings account and the life insurance, which I hope I know where the board is going, and then we can table the other 3 items. And if there's anything else they need to vote on, if there's anything else they need to vote on from our discussions. No, just those 2 things.
May I comment? They may not be needed to vote on today, but what about the deductible change for the CDHP? Is that something you'd like to consider today?
This is Celestina Glover for the record. If you want to maintain the HSA, you don't have a choice.
Right.
There's no vote on that one. That was informational because to maintain our eligibility to provide that, unless the board wants to decide to put the HSA, and then it will really blow up. There's way more people getting HSA money than there are people on the HMO.
I request we break for lunch. and we can have that discussion.
Michelle Kelly for the record. So just a comment firstly. I think that being able to show employees what the PPO structure will look like, especially since the proposal is to go to majority of co-pays, which will probably be 90% of common items. I think that will go a long way to assuading a lot of the concern we've heard. Obviously, the network is a different piece, but I think that co-pay, seeing that laid out is why I would like the extra time so our participants can actually see it and engage that it looks like they can afford to seek services when they need to. So saying that, I will make a motion per the agenda item to a motion to approve the proposed increase to the HSA and HRA to $700 for the primary participant and $200 for each dependent, up to a maximum of $600 for those enrolled in the CDHP. And I also make a motion to maintain the new life insurance benefits at $25,000 for employees and $12,500 for retirees for all primary plan members.
Betsy Strasburg, so second.
We have the motion and the second. Is there any further discussion? Okay. I'll call for the vote. All those in favor signify by saying aye.
Aye.
Any opposed? Okay, motion passes. We'll move on to agenda item number 7, public comment period.
We don't need to make a motion on the transition of PPO and other things. To table it.
I mean, it may be best to be said.
Okay.
To cover all bases.
Okay.
Betsy Strasburg, I make a motion to table the transition to the LDPPO to a standard PPO plan and also the elimination of the EPO and the HMO plan for the November meeting.
Okay. Do we have a second?
Michelle Kelly for the record. I second.
All those in favor?
Aye.
Anyone opposed? Okay. Okay, now we'll move on to agenda item number 7, public comment period. Public comment will be taken during this agenda item. Comments are limited to 3 minutes per person.
Hi, again, I'm sorry, the first time I spoke, I didn't spell my name. First name is Lisa, Lisa, last name Partee, P as in Paul, ART as in Tom, EE. I'm glad Kelly brought up the Carson Tahoe issue. And I hope that it can come to a good conclusion. And I hope, because Carson Tahoe basically is a monopoly. That's where the majority of our doctors and specialists are. So I hope that with this UMR, my bills are getting paid. So I'm not sure what Carson Tahoe is talking about, because my bills are being paid very efficiently. I get my explanation of benefits, and I'm not seeing any problems with UMR paying for my insurance or my bills. So I hope that maybe you guys get this worked out with Carson Tahoe and try not to let them drop us, because otherwise it's gonna put us in a big bind, especially people that have significant issues. Anyway, thank you again for today. Appreciate it.
Thank you.
Chair Grimmer, I received comments from two participants who are unable to get through in the phone lines. So with your permission, if they can't get through now, I would read their comments into the record later.
Okay.
For my own comments, Kent Irvin, ERVIN, Nevada Faculty Alliance. First of all, please trust our members to know their needs. While there may be some misunderstandings out there about out-of-pocket maximums and so forth for the various plans, they do know what they are paying now and how they're being billed and what their risk tolerance is. So please listen to our members. And then I have just a few reactions to things that have been said today. We talked about wanting to stabilize the benefits, for example, for the life insurance. I totally agree with that. That applies even more to maintaining the 3-plan structure. That's part of our benefits. We want to keep that stable. It was mentioned that dividing the same state funding between 2 plans versus 3 plans would be advantageous. I don't understand that, because the state subsidy is on a per employee basis. So it doesn't matter how many different plan choices there are, it's the same funding per employee. So I just don't understand that comment. As far as the cost of the EPO in the north versus the HPMO and the cost, we know healthcare costs are different geographically in the state, regardless of the plan. It's just that for those 2 plans, because they're separated geographically, you see the numbers. For the other 2 plans, those cost differentials are there, they're just in the totals. So our position has always been that state employees should be treated the same regardless of where they live or work, as far as their benefit costs and so forth. If conditions are so different in the north and south that needs to be changed, that's a major discussion to have. But it's not just the EPO versus HMO. It's the cost of healthcare in the state and how different it is in different areas. It was the low non-state retiree numbers was mentioned. That's a separate problem that applies to all 3 plans. At some point, those non-state retirees will have, as their numbers decline, because we aren't getting new active employees into those plans, they'll need to be merged into the state member group for rate setting purposes. But that's a legislative issue. That may be something you want to bring to the legislature next time, if the numbers are now so low that it doesn't make sense to rate them separately. It was mentioned that the low numbers in the EPO will make it unsustainable at some point. I kind of understand that, but my understanding was that all of the self-funded plans were being underwritten together as far as the claims costs. And so I don't understand why low numbers in one of the 3 makes that much difference if we are now, as I understood it, doing the underwriting altogether anyway. Finally, please just don't make major structural changes, at least until FY 2027, that is to start in July 2026. Doing this again when you're under time pressure and you don't know what the legislature is going to fund means that we're just doing things in the dark and we're changing benefits to meet some goal that we don't really know is there or not until the legislature meets. So if you want to develop a plan through strategic planning and put it forward for the 2nd year of the biennium, then that can be presented to the legislature and you can get buy-in and maybe funding for it. But doing it when the board doesn't have all the information is problematic. And finally, you've got this RFP evaluation committee. The statute allows any number of board members to be on that evaluation committee. So all of you could be on it and get that information confidentially. I know it's a lot of work and time, but if more board members are on that evaluation committee, keeping the bids confidential, that's the point. But at least you would have input on the future of the HMO plan by knowing what by rating those bids according to how they come in. So that's my suggestion for that. Put as many board members as possible that you can do on the evaluation committee. So thank you. And at the end of public comment, I'll come back with those other statements.
Any other public comment?
Hello, thank you. My name is Kelly Osborne, KELLYOSBORNE. If I may make a comment about these plan structures. Prior to me getting sick, I was on the EPO plan, and I was on it because of an aversion to risks. And I was not aware of the 20% co-insurance until I got sick, until 3 weeks in a hospital landed me with over $1 million worth of hospital bills. So that had changed over during COVID to the 20% co-insurance. And when they had the open enrollment and that was discussed, it was just glossed over. So when you have open enrollment and you make these decisions and you are informing your members, if you could please make sure they know of the specific plan changes, because I almost went bankrupt over this. So because I thought I was in a low risk program, I thought I was just going to have to pay $350 out of pocket. And then it was crazy. So if you guys could be very mindful when you're informing your members of these significant plan changes, I'd greatly appreciate it. Thank you so much.
Thank you. Any further public comment in Carson? Okay. We will move to the phones.
One moment, Madam Chair. Get the slide up. As a reminder, joining the Zoom meeting as an attendee is for making public comment only. If you do not wish to make a public comment, please leave the meeting so you're not accidentally called upon. Please watch it via the YouTube live stream on the PEB YouTube channel. The link to the live stream is also located on the agenda of the PEB website. For those who have joined for public comment, your name or the last 4 digits of your phone number will be announced. You have been advised you have been unmuted. Please slowly state and spell your name for the record and then proceed with your comments. Debbie Ortega. Please.
Yes, DEBBIEAR, T as in Tom, EAGA. I would want to point out that in terms of our faculty, we do not make astronomical salaries, especially those who are new or administrative faculty who include advisors. So any increase in premiums. I would also like to state that the purpose of health insurance is to protect us all. And if you only need to go to the doctor once a year, then you're subsidizing those members who really need health care. I would also like to say to board member Kelly, I know you received 43 emails. I lost count. So this is a matter of great seriousness. And I do want to make a statement of the low deductible PPO, the $500 maximum for outpatient surgeries and the $750 for the ER. I understand from the plan structure that they want us to go to urgent care, and I appreciate that. However, if you have an asthma attack at 2 o'clock in the morning, like I did, you don't have any choice. You have to go to an ER because there's no urgent care open. It's an expense for me. I could shoulder. For a lot of our employees, they cannot. So they have to make a decision does my child really need to go to the ER, or can I wait for the next day? And I do think that that is of great concern to a lot of our employees. Thank you.
Thank you. Amelia Davis, please slowly state and spell your name if you wish to make public comment.
Hi, my name is Amelia Davis. First name is spelled Amelia. Last name is spelled Davis. I have a prepared statement, but I would like to thank the board members really quickly who championed the HMO. You understand this is more of an emotional toll on us rather than purely financial. I have been the graphic designer and creative coordinator for UNLV for about 2 years now. I'd like to make my comment against the cancellation of the HPM HMO plan. As a chronically ill individual myself who relies on this coverage, this plan best supports my frequent doctor's visits and monthly medication expenses. Without this plan and its predictable exact co-pays, I understand that I would not be able to afford much of my healthcare needs. Additionally, as the healthcare in Nevada has consistently been ranked one of the lowest in the nation, I know that I am personally incredibly lucky to have the doctors that I do that fight for my care and take me seriously as a single female patient. I am understandably afraid to lose some of my amazing healthcare providers should the HMO plan be terminated. The legwork that is also required to find new doctors, especially ones that will take my health personally, is incredibly daunting. Lastly, I implore you all to remember well that many of us state workers feel that the benefits provided to us are a very important part of feeling valued and appreciated for the work that we do, and that the state takes care of us in turn. Thank you.
David Kelsey, you have permission to speak. Please slowly state and spell your name for the record. I've been communicating with Kent Urban, and he's going to make David Kelsey's statement for him. Sorry, I apologize in advance, or apologies for the technical issues, David.
I'm speaking on behalf of David Kelsey, David Kelsey. My name is David Kelsey. I am deaf. I'm here to express my concerns regarding potentially eliminating HMOs. My husband suffers from a chronic illness, so I strongly advise against discontinuing HMOs. We would face difficulties in the absence of HMOs. Thank you for your time, David Kelsey.
Thank you, Mr. Irvin. Will the caller with the last four digits 0891 please press *6 to unmute, and please slowly state and spell your name for the record if you wish to make public comment. Caller with the last four digits 0891.
Can you hear me okay now?
Yes, we can. Thank you.
Thank you. Good morning, Chair Grimmer, Executive Officer Celestina Glover, board members, staff, and guests. My name for the record is Terry Laird. I'm the Executive Director at RPEN, the Retired Public Employees of Nevada, a nonprofit, nonpartisan organization where we represent nearly 7,000 dues-paying members statewide. I'd like to continue my request that I mention nearly every board meeting regarding retirees in the Medicare exchange have in recent years abandoned mailing newsletters and important information, favoring instead to place all of this information online. I can tell you many of our members still do not use the internet, preferring instead to talk with someone or on the phone, or in person. The upcoming open enrollment is a perfect example of the importance of information that PEB and VIA benefits has for retirees in the Medicare exchange. They have been told many times they must stay within VIA benefits if they want to keep their benefits, as Ms. Glover mentioned during the meeting today. But confusion arises when the all too good to be true offers begin arriving in the mail and on TV. I received such an offer myself this week, weeks before October 15th. We wish some of this valuable information about the risk during open enrollment could be disseminated more than just online. Moving on, RPEN is happy to see life insurance amounts which were raised at the 2023 legislative session remain the same in this new budget. I too am interested in seeing additional legislative discussion at the next session about raising the HRA health reimbursement arrangements for Medicare retirees. One last concern I have is with the fourth quarter update from VIA Benefits about their HRA available balance cap of $8,000. This report states that effective May 31st of this year, they processed the annual $8,000 HRA available balance cap reduction, impacting 605 accounts with over $1 million of adjustments being made to the available balances. Now that these funds have been removed because they're over the $8,000 cap, they can't be added back. This is another one of those issues that many retirees still are not aware is happening. They need more education and/or assistance to know of the many uses this money can be used for so they don't lose it. Thank you, and we appreciate PEB and their staff for assisting our members with issues because they contact us when they can't get help any other way. Thank you again.
Thank you. David Cooper, you have permission to speak. Please slowly state and spell your name for the record if you wish to make public comment.
Hello, my name is David Cooper, DAVID COOPER, and I am an assistant professor at Nevada State University, and I'm also the serving chair of the Faculty Senate at NSU. I thank you for tabling the change in plans that give us ample time to review the proposed changes. The conversation, the HMO has largely been based around only the total yearly cost comparison between the different options, and I would like to emphasize two important points. The first being that unexpected costs can occur at inopportune times and cause an imbalance in pay for medical emergencies on the LDP-PPO plan and the CDHP plan that is mitigated by the steady costs found in the HMO plan.
Excuse me. This is the court reporter and you're reading way too fast. If you could take that down a little bit slower, I'd appreciate it. Thank you.
All right. Sorry about that. So the first being unexpected costs can occur at inopportune times and cause an imbalance in pay for medical emergencies on the LDPPO plan and the CDHP plan that is mitigated by steady costs found in the HMO plan, especially if these costs occur at the beginning of the year when out-of-pocket costs have just been reset for the year. This steady payment plan provides peace of mind to know well ahead of time what medical costs will be and be able to be budgeted accordingly. The other is the availability of providers is not the same for the different plans, that a forced switch to a new plan will cause stress and instability for participants of the HMO plan. While it is impossible to predict whether providers will still be supported on plans in the future, it is almost guaranteed that there will be a disruption for those members who are forced onto other plans. I therefore urge caution and thorough examination of these issues when considering change in plan options. Thank you.
Thank you, Mr. Cooper. Mary M., you have permission to speak. Please fully state and spell your name for the record if you wish to make public comment.
Hello, my name is Mary McCurchian. For public record, M-A-R-Y, last name M-K-R-T-C-H-Y-N. And I would like to greatly appreciate the board members today and for their time and dedication to helping state employers. My concern is that I've been continuously going to doctors' offices and specialties to address my medical concerns. And so having that predictability and also knowing how much I have to pay out of pocket upfront is a huge importance, because then I don't have to worry about that extra stress or if I have to see with my budget or anything along those lines. And my position here at UNLV does not require me to travel. So most of my visits are within the in-network providers. And I know there might be other out-of-network within the same state, but I typically stay within that region. It's just my concern is knowing how much I have to pay, making sure I have coverage, and being informed if I have to reinstate to a different plan, or would I be automatically placed into a different plan. And I apologize, this is my first time making a public comment, so if it's not making any sense, I greatly apologize for that. And I am an administrative faculty here at UNLV, and I'm the site coordinator. Thank you so much for your time.
Thank you. Ozioma, you have permission to speak. Please slowly state and spell your name if you wish to make public comment. Stacy Wallace, you have permission to speak. Please slowly state and spell your name for the record if you wish to make public comment. V. McFadden, you have permission to speak. Please slowly state and spell your name for the record if you wish to make public comment. Madam Chair, Mr. Urban has one more comment.
Okay, go ahead.
Thank you very much. I have a comment from Laura Nauman, who was unable to get through on the phone line. Laura Nauman, LauraNaumann. Executive Officer Glover and the consultant continue to oversimplify the out-of-pocket expenses that the HMO participants are incurring via monthly premiums compared to PPO participants to fit their narrative. I am fully aware that I pay a higher per month premium, totaling approximately $1,200 over the year than those on the PPO. I do so because I value predictable pricing and never second guess whether to go to the doctor because I'm worried about unexpected costs or procedures that may not be fully covered. Every year, I use all of my preventative screenings, for example, annual PAP, annual checkups, labs, mammogram, and I don't receive any bills for these. What EO Glover and the consultant are failing to discuss is the unpredictable cost incurred at any given health visit or emergency event to PPO participants. Some visits could have low costs, but others could require a lump sum payment of greater than $1,200 in one fell swoop that many Americans have not budgeted for or could not afford. EO Glover discussed the possibility of moving to a copay only option for the new PPO that wouldn't have coinsurance, and I think that would be an important consideration if we are eliminating the HMO. I just have no idea what my visits, preventative care, and lab testing prices would look like if I were on the PPO, and it would be a rude awakening to start receiving those bills. There will definitely need to be lots of messaging to HMO EPO participants on what is changing and what kind of pricing we should expect. Finally, no one has addressed the availability of providers for the influx of HMO members and ensuring that there's adequate quality coverage for all forms of healthcare, including mental and behavioral health. That's the end of the comment. Thank you for your indulgence, and thank you all board members for your discussion today.
Thank you.
Madam Chair, looks like Debbie wants to raise her hand again.
Okay.
Debbie, you have permission to speak. Please slowly state and spell your name again.
I don't think I hit my 3 minutes, so I'm just going to say a couple of things. Thank you, board members, for agreeing to table this critical decision. I know that I speak on behalf of all the faculty, administrative, and academic at UNLV in giving you my thanks. I understand that because you posted the agenda, it does not only sending the email to all of us on Tuesday at 10:01 a.m. does not violate Nevada public meeting law. But what I would like to respectfully request is that when this is posted on your website, if you could send out the kind of email that you sent out on Tuesday. Thank you so much.
Thank you. Madam Chair, that concludes public comment.
Okay. Seeing no further public comment here in Carson or online, we'll close agenda item number 7, and we will adjourn. Thank you.